MedTerm Presence in Obstetrics Lecture on. MedTerm Presence in Obstetrics Lecture on. The Neonate taken from Chapter 16 of Obstetrics book. By 10 Teachers 20th edition. Neonatal. Babies undergo various transitions after being born. Physical. Draining of lung fluid, anatomical and physiological. Reduction in pulmonary pressures allowing increased blood flow and closure of ductus arteriosus, adjustment growth. Airway. After birth, the airways can be blocked by mucus. The head is relatively large, the neck is short and the occiput is prominent. The larynx is anterior and high. Combination of these features mean that airway can be maintained by using a neutral position. At birth, the lungs are very stiff because they are filled with fluid. It is important to establish a functional residual capacity to make sure that some air is left in the lungs after maximal expiration. Healthy babies do this by crying and deploying surfactant. Fetal lung fluid is cleared via lymphatics in an hour after birth. Cardiovascular system. Stenosis, closure of ductus arteriosus. Delay in closure can be due to acidosis, meconium aspiration, cold or for no reason. It can lead to hypoxia and sick baby. Blood flow to lungs increase. Metabolic baby needs to adapt from a continuous infusion of maternal glucose via the placenta to intermittent feeds. Healthy term babies can cope with gaps between feeds because of adequate stores and functional endocrine. Healthy term babies can cope with gaps between feeds because of adequate stores and functional endocrine system. Hypoglycemia can be due to low stores, inadequate hormonal response, maternal drug intake like catecholamines, maternal diabetes leading to fetal hyperinsulinemia, feeding difficulties. Most of these factors are present in preterm, growth restricted or infected babies, severe sugar in any unwell baby. Neonatal. Bilirubin liver enzymes take 3 to 4 days to a week to reach adequate levels. This leads to jaundice due to raised unconjugated bilirubin. This physiological jaundice appears in 2 to 3 days. Jaundice within 24 hours is pathological and needs extensive review. Raised conjugated bilirubin may mean biliary atresia or tumors. Neonatal jaundice include abnormalities of red cell enzymes or morphology, extravasated blood, e.g. cephalohematoma, increased enterohepatic circulation and endocrine conditions such as hypothyroidism. Appropriate investigations are undertaken if the clinical course suggests they are needed. Treatment is based on phototherapy, which uses light in the visible spectrum. Treatment is based on phototherapy, which uses light in the visible spectrum to conduct a photoisomerization of toxic bilirubin to safe isomers, some of which are excreted rapidly. If phototherapy fails, exchange might be needed. Involves withdrawing a small aliquot of blood from the baby and replacing it with a small aliquot of cross-matched blood. This is repeated every 5 minutes over 4 hours. The aim is to replace twice the baby's circulating volume. WIC is 130 ml/kg. Renal and immune system. Before birth, placenta acts as kidney. After birth, there are shifts in renal blood flow during the week after birth that lead to increased renal function. Newborns have immature cellular and antibody response to pathogen. Endocrine system. The most common neonatal endocrine problem is maternal hypothyroidism, which can cause symptomatic neonatal hypothyroidism. Babies with symptoms of thyroid disorders are rare and need urgent attention from an experienced pediatric endocrinologist. Weight loss. Newborn babies lose weight in the days after they are born. This reflects a loss of extracellular fluid. Healthy term babies can lose 10% of their birth weight and get back to their birth weight within 1 week. Deviation from this limit may indicate a pathology. Term breathing difficulty. In a newborn baby, the airway needs a neutral position, i.e. no flexion and no extension of the neck. Excessive suctioning can cause bradycardia. Breathing difficulties that persist despite initial supportive care may be due to surfactant deficiency, transient tachypnea of the newborn, meconium aspiration or infection. Surfactant deficient lung disease, SDLD in term. It is more common in the infants of insulin-dependent diabetic mothers. Managed with supplementary oxygen, ventilatory support and the administration of surfactant. The chest X-ray shows evidence of alveolar fluid with a ground glass appearance or air bronchograms. Apnea of the newborn. The condition gradually resolves over 1 to 3 days. This condition is thought to be caused by the persistence of fetal lung fluid. More common after caesarean section in the absence of labor. Treated conservatively with supplementary oxygen as required. Chest X-ray is relatively clear and can show perihilar shadowing and fluid in the lateral fissure. Now we are left with the meconium aspiration syndrome. It is a chemical pneumonitis. Clinically significant meconium aspiration occurs before birth. The condition gets worse over 24 to 48 hours and then gradually improves. Clinically relevant meconium aspiration requires mechanical ventilation. Babies with meconium aspiration may benefit from surfactant. Extracorporeal membrane oxygenation is an option if babies are not responding to optimal medical care. Require inspection of the vocal cords if they have respiratory difficulties. All babies with significant respiratory distress are treated with antibiotics until infection is ruled out. Discuss some of the suspected bacterial infection. These can be early onset infections, group B streptococci referred to as GBS in the upcoming slides. GBS is most common. Women colonized with GBS are at increased risk of having a baby with invasive GBS. B streptococci colonization triggers intrapartum antibiotic prophylaxis, which reduces the incidence of invasive GBS disease. GBS is susceptible to benzyl penicillin. Therefore, benzyl penicillin is a useful agent for IAP and treatment. Treatment course for proven GBS infection is at least 7 days. GBS colonization triggers intrapartum antibiotic prophylaxis, which reduces the incidence of invasive GBS disease. GBS is susceptible to benzyl penicillin. Therefore, benzyl penicillin is a useful agent for IAP and treatment. Treatment course for proven GBS infection is at least 7 days. Escherichia coli is a gram-negative bacteria. Gentamicin is used for the initial treatment of E. coli and other gram-negative bacteria. Haemophilus influenzae, it is an occasional cause of early-onset neonatal infection due to vertical transmission. This is due to non-encapsulated, non-serotypable forms that are not covered by the routine immunization against H. influenza B. This is treated with cefotaxime. Now we'll discuss some late-onset infections. Neonatal meningitis. Early or late neonatal infection can be associated with meningitis, which is often associated with a poor outcome in childhood. Meningitis may not have clinical signs, and neonatologists have a low threshold for performing a lumbar puncture. Then we come on to the syphilis. Babies born to women with positive treponemal serology need clinical evaluation and syphilis serology testing. Babies are treated if congenital syphilis is suspected or maternal treatment is within 4 weeks of birth or incomplete. The usual treatment is intravenous benzyl penicillin for 2 weeks or more. Certain viral infections as well, for example herpes simplex, neonatal herpes simplex virus HSV, infection is often fatal. That is 20% and leads to significant disability among survivors, more than 60%. Neonatal HSV is usually vertically transmitted. If an active maternal primary infection is underway at the time of birth, the baby has a 50% risk of developing systemic herpes. Infection is an effective way to reduce the incidence of infection among women known to have primary genital herpes. Neonatal HSV infection presents in 3 ways: localized, central nervous system, and disseminated. The localized form is relatively benign, but the neurological and disseminated manifestations of neonatal HSV are severe illnesses, often requiring extensive intensive care. The treatment is intravenous acyclovir. There is another commonly encountered viral infection, which is varicella zoster. Neonatal varicella occurs in the babies of mothers who develop chicken pox. If the baby is born more than 5 days after the mother develops the rash, then transplacental antibodies provide some protection and the illness is not severe. Babies of women who develop chicken pox 7 days before or 7 days after birth should receive zoster immunoglobulin. If a woman has shingles, then the baby is protected from infection with varicella zoster virus by maternal antibodies. Mother and baby can stay together. Human immunodeficiency virus. Human immunodeficiency virus. Babies born to women with a low viral load less than 50 HIV ribonucleic acid (RNA) copies ml plasma should receive monotherapy with zidovudine for 4 weeks. It is very important from examination point of view that you remember zidovudine if a woman has more than 50 HIV RNA copies, ml plasma or maternal HIV is diagnosed within 3 days of birth. Combination post-exposure prophylaxis with 3 agents should be started under expert supervision. With appropriate post-exposure prophylaxis, less than 1% of babies born to HIV-positive mothers will be infected. In the absence of post-exposure prophylaxis, 15% of babies born to HIV-positive mothers became infected. Only with cytomegalovirus, symptomatic congenital CMV causes learning disabilities or sensorineural hearing loss. Congenital CMV can be treated with ganciclovir intravenously for 6 weeks. This reduces the severity of CNS damage and hearing loss. Many countries offer screening at birth. Discuss seizures. Another very important topic. Half of the babies with seizures develop neurodevelopmental abnormalities. Causes include hypoxic ischemic encephalopathy. Most common cerebral infarction, stroke, intracranial hemorrhage, intraventricular hemorrhage and subdurals, meningitis, electrolyte disturbances, hypocalcemia, hypomagnesemia, hypoglycemia. Encephalitis, clinical condition suggesting brain injury. Conscious level and tone can be either increased or reduced. Causes include hypoxic ischemic encephalopathy, infection, drugs, CNS malformations, metabolic derangement. Jitters are not seizures. Amplitude integrated electroencephalography (AID) or cerebral function monitoring (CFM), brain magnetic resonance imaging (MRI) is the first-line imaging modality. Autonomic changes, respiratory rate, blood pressure, oxygen saturations, SARNAT grading can be used, which is given page 306 of the OBS book by 10 teachers. Table 16.1. MRI altered signals at basal ganglia indicates rapid onset of hypoxia. Altered MRI signals at cerebral levels indicate a more chronic cause. Basal ganglia damage can cause dyskinetic cerebral palsy. Internal capsule injury results in upper motor neuron lesion. Cortical injury leads to learning difficulties. Prognostic features include rapid return to normal behavior, rapid return to normal CFM, normal brain MRI, oral feed started within 7 days. Bad prognostic features include prolonged resuscitation, seizures within 6 hours of birth, unresponsive to stimulation, no gag response when off all medication, multi-organ failure, burst suppression pattern on the CFM. Start treatment while diagnosis is awaited. It may take a week. Supportive care. Airway, reduced tone in pharynx may need intubation. Breathing, ventilatory support may be needed. Circulation, poor myocardial function may need ionotropic support. Renal assessment by output monitoring. Therapy. HIE suspected antibiotics for infections, phenobarbital to control seizures. Supplementary agents like midazolam, levetiracetam, phenytoin and sodium valproate. Screening important to screen for conditions difficult to diagnose antenatally. 3 components: physical assessment, hearing check, blood test, examination, head-to-toe examination to detect any abnormality or joint dislocation, especially hip laxity or dislocation, congenital cataracts, heart murmurs, pulse oximetry for postductal hypoxia, head circumference, external genitalia. UK hearing tested by otoacoustic testing. Clicks are played in baby's ear. Healthy cochlea responds by making sounds which can be detected. Resource constraint setting. Need to monitor behavior and learning ability. Blood spot testing. Babies are screened for diseases. Early intervention for which can improve prognosis. Screening in UK done for sickle cell anemia, cystic fibrosis, congenital hypothyroidism. 6 Metabolic conditions screened for phenylketonuria, medium chain acyl-CoA dehydrogenase deficiency, maple syrup, urine disease, isovaleric acidemia, glutaric acid, urea, type 1 homocystinuria. UK, the national immunization schedule is available online. 2 vaccinations are given: hepatitis B to those whose mothers are positive for it. Immunoglobulins are given to babies whose mothers do not have anti-E antibodies. BCG is given to babies coming from areas with an incidence of TB of 40 in 100,000 or whose parents or grandparents are from countries with an incidence of TB of 40 in 100,000. In Pakistan, vaccination is done for tuberculosis, diphtheria, polio, hepatitis B, Haemophilus influenza, pneumonia, and measles. The diagram shows the EPI vaccination schedule. This is simply UNICEF representing the expanded program on immunization in Pakistan. Babies divided into according to care needed. Less than 29 weeks. 29 to less than 37 weeks. Greater number of babies fall in this group. Problems arise because of delays in adaptation adjustment growth. This slide shows the consequences of prematurity that include neonatal, short-term and long-term consequences. All of these are discussed in the coming slides. Risks to preterm babies. Care of preterm babies includes steroids injections to mother in whom preterm labor is anticipated, shift to facilities where ICU care available, magnesium sulfate given during labor for neuroprotection after delivery, maintain warmth by keeping in warm room, plastic bags may be needed, minimum handling to minimize infections, optimize nutrition. Continuous positive airway pressure may be needed to overcome atelectasis. Intratracheal surfactant administration through endotracheal tube may recover from a few days to few months. Lookout or infections. Antibiotics may be required. Expressed breast milk is given either through bottle or enterally, as required. Necrotizing enterocolitis appears as abdominal distension, blood in stools, and intolerance to feeds. Require triple antibiotic cover and surgery. Preterm baby should be screened and treated for retinopathy by laser intraocular injection of antibodies against endothelial growth factors. Kangaroo mother care. It is an evolving concept. The kangaroo mother care refers to the practice of providing continuous skin-to-skin contact between the mother and the baby, exclusive breast milk feeding, and early discharge from the hospital. It promotes beneficial effects both for the mother and the baby. It is important for the preterm babies less than 2,000 grams as well as the clinically stable, those who do not require recurrent resuscitation. There are many known benefits of kangaroo mother care. Common conditions in medicine units include hydrops fetal, which is a life-threatening problem of severe edema in the fetus and newborn. Presents as effusion and ascites. Treatment depends upon the cause. There can be effusion syndrome, the other diagram shows. Selective laser photocoagulation. Traumatic hernia. Surgical. This diagram shows gastrostosis. This shows the repair using spina. There are various types. Spina bifida occulta. Meningocele. Meningomyelocele. Myeloschisis. Spina bifida. Treatment. Wrap to prevent handling and infection. Planned surgery within 48 hours. See complications: hydrocephaly, limb paralysis, urinary and fecal incontinence. This lecture on the neonate. Fetal assessment starts from antenatal period. The steps of transition and physical and anatomical adaptation are required before growth starts. Newborn care includes assessment for physical deformity, respiration and circulation. Teamwork is required to address the varied issues of a sick baby. Many advances now give a better prognosis in fetal medicine. Thank you for watching. Subscribe MedTerm for more videos and updates.